Welcome to the CMEssentials podcast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello, and welcome to another installment of Oakstone's CMEssentials in Internal Medicine. I'm your host, Dr. Michael Krug. I am an assistant clinical professor of medicine at the University of Washington School of Medicine. I'm also the associate program director for the University of Washington's Boise Internal Medicine residency based in Boise, Idaho. Unbelievably, this is already our 11th episode of this formerly brand new audiocast. I don't think we can call it brand new for much longer. In this 11th episode, we'll explore the topic of atrial fibrillation. Joining me as our expert is Dr. Zachary D. Goldberger, professor of medicine in the Division of Cardiovascular Medicine at the University of Wisconsin School of Medicine and Public Health. He's the program director for the Cardiovascular Disease Fellowship at the University of Wisconsin, and he's active in the American College of Cardiology, the American Heart Association, the Heart Rhythm Society, and the American College of Physicians. When do you find time to sleep, Dr. Goldberger? I don't know. But perhaps most important for today's purposes, he was a writing committee member for the 2023 ACC and AHA guidelines for the diagnosis and management of atrial fibrillation. Thank you so much for being here, Dr. Goldberger.
Thanks for having me.
Our discussion is presented in two parts. In part one, we'll discuss rate control versus rhythm control strategy, as well as the newly created stages of atrial fibrillation, which to me seem to mimic the stages of heart failure, but we'll see what Dr. Goldberger thinks. Then in part two, we'll turn to diagnosis, duration, and anticoagulation strategy in atrial fibrillation. We'll talk about left atrial appendage occlusion or ligation, and we'll also touch on the always confusing to me anyways, valvular atrial fibrillation and what that means. We've got 3 case studies interspersed within to help bring our discussion to life, and we'll end each part presenting key take-home points. Let's get started. First topic, rhythm control versus rate control strategy in atrial fibrillation. So when I was an early career physician about 15 years ago, almost all the patients I cared for with atrial fibrillation were following a rate control strategy. But these past few years, both in the clinic and in the hospital, the tide seems to have turned, and increasingly more of the patients I see are being directed towards a rhythm control strategy. Dr. Goldberger, have you noticed this also? And what do you think might be the reason behind this shift?
Yeah, so I think it depends on who you see, but I tend to agree with you. Just to take a step back, I think the impetus for deferring rhythm control for rate control was driven by the landmark trial called the AFFIRM trial, published in New England in 2002, that basically just evaluated rate versus rhythm control in around 4,000 high-risk patients, and that showed no difference in mortality. And there were risks associated with rhythm control, and that was achieved with cardioversion and antiarrhythmic drugs. So based on that trial and other meta-analysis, showed that there's actually not a marked difference between major endpoints as far as rhythm or rate control. And especially antiarrhythmics being pro-rhythmic, oftentimes the rhythm control strategy was deferred. So someone who's older, a lot of comorbidities, will have a lot of contraindications for AEDs, higher procedural risks. In that case, a rate control strategy may be best. But you see someone who's younger, possibly who has a little bit of LV dysfunction, who doesn't have a lot of risks, you might be thinking about a rhythm control strategy as an alternative. And the guidelines confer a class 1 indication for shared decision-making regarding both strategies, which is imperative. But as you alluded to, there's more sort of enthusiasm for rhythm control based on recent trials, especially the East AFib trial.
So if I heard you right, Dr. Goldberger, it's still individualized, but maybe there is a little bit more appetite for a rhythm control strategy, in part based on this trial that you mentioned, the East AFib trial, if I pronounced that right. Interesting. And so looking back at the guidelines, which I have looked over that you in part wrote, the 2023 ACC-AHA atrial fibrillation guidelines give a class 1 recommendation for shared decision-making with the patient when deciding between a rate and rhythm control strategy. This seems like a good time to bring in a patient case into the discussion. Let's hear from Dr. Lydia Calamari, an internist at HM Health in Charlotte, North Carolina.
Clara is a 71-year-old with well-controlled diabetes and hypertension who presents in follow-up of a recent diagnosis of atrial fibrillation. 1 month ago, she went to the ED with palpitations, shortness of breath, and swelling of her lower extremities. She was found to have AFib with RVR. Her workup there included serum electrolytes, complete blood counts, thyroid studies, and a chest X-ray, which were unremarkable. After her heart rate was controlled, she was discharged and sent for an echocardiogram, which showed a moderately dilated left atrium, normal diastolic and systolic function. Today in the office, she continues to feel well, denies palpitations, dyspnea on exertion, or edema. On exam, she is well appearing, with a blood pressure of 125/60, heart rate 75, oxygen sat of 98%, and her cardiac exam is notable for irregular rhythm and no edema. EKG confirms atrial fibrillation. While she feels well, she does endorse some concern about her condition. Her sister was also recently diagnosed with AFib and had an ablative procedure, which ultimately stopped the AFib. She would like to know if this is something she needs to consider or if there are other treatment options. How would you counsel this patient, and what would you recommend?
Thank you, Lydia. So we've got an interesting case here. So Zach, can you walk our audience through your approach to this conversation that you would have with this patient?
So I think that what we just discussed, there's a new enthusiasm for early rhythm control based on East AFNet, and that was published in 2020. What that did was randomize about 3,000 patients with early onset AF within a year and other risk factors for stroke to rhythm control or rate control. So it was a little bit different than the enrollees in the AFFIRM trial. And they found that rhythm control was superior to usual care, which was rate control, with respect to time to adverse cardiovascular outcomes. And in that situation, it was interesting that the rhythm strategies, they used drugs. The most commonly used drug was flecainide, which is a little bit different than the way we oftentimes practice, followed by dronedarone and amiodarone. Only 8% were ablated in this trial at the beginning, and by the end of the year, only 20% had received ablations. So this is not about ablations. This is about trying to get people into rhythm control earlier. And so, reconciling that difference between AFFIRM, there's lots of reasons why those differences may be present. Older patients, East AF finishes were generally healthier. And so the strategy is slightly different too. But I think that this is actually important because now it sort of talks about why you might be recommending a rhythm control strategy earlier on. The patient in this case is very classic. This is what I see in clinic all the time, or at least variations of this theme. She's coming in with a high-risk demographic for new AFib. She's been appropriately started on the right medications, resting heart rate of about 70, and just having a good response in that situation to her AV node blocker. And it's fine knowing that her LVF is preserved. She's got a CHA2DS task of 4 based on her age, her gender, her diabetes, and her hypertension. And she's also appropriately on anticoagulation. So I think that what I would discuss is I would think that, number one, I'd likely continue her on her current medications, then discuss what we know about rhythm and rate control based on the trials I just mentioned. I'm talking about AFFIRM, talking about East. I would discuss with her rhythm control based with the cardioversion and possibly the need of repeating it on a drug with continuation of that drug if it occurred. I would also introduce the concept of AFib ablation, where that discussion can oftentimes be overwhelming for people at the first visit. I'm talking about a lot of things that are new. So I usually frame it as there's a more procedural way of maintaining rhythm if drugs were not effective or they weren't desirable. I also discuss rate control. That for her will be entailing continuing her on her same drug regimen. And if that's the case, I recommend a 48-hour Holter monitor, 24 to 48, to understand how well rate controlled she is. Because if she's walking into the clinic in the 70s, it's not clear to me that when she walks out of clinic or does her normal daily activities, she may be tachycardic for a lot of that. Also, you want to figure out if she's got prolonged pauses, whether she's persistent or not. These things oftentimes affect the calculus of how safe beta blockers really are. And most importantly, we also discussed modifiable risk factors, especially lifestyle.
Okay, that was awesome. I got a lot from that, Dr. Goldberger. Interesting. I hadn't thought of this, and maybe that's why you're the cardiologist, but her heart rate she comes in and it's 75 or 80, so not bad. But you said maybe doing a 48-hour Holter to see whether it's always around there, or whether she dips too low or too high. And so really assessing whether her rate control strategy is truly adequate. You brought up the concept of comorbidities and how they might be impacting things and how we can address those and maybe help. And then also, I love this patient-centeredness, that this might be overwhelming. Maybe you can't cover 100% of the guidance for this individual at the first visit. So maybe we need to tailor things. I love it. Okay. So let's say if this patient says, thank you so much for all this wonderful information, Dr. Goldberger. I don't really know. I'd like you to give me a recommendation as to whether I should pursue rhythm or rate control strategy. What do you think you would say?
I think at this point, I favor rhythm control. This is not based on what we always hear. People say, well, every patient deserves a chance at sinus rhythm. That's a gross generalization. It's highly impersonal. So I think that every patient I see is different with AFib. While she doesn't have symptoms, I find that most patients actually do feel better in sinus rhythm, even if slightly. We see the suggestion of that in the AFFIRM trial, that sinus rhythm may have conferred a little bit of quality of life. It's not clear. But recognize that, patients have gotten so used to persistent AF, they actually forget what it felt like before they developed it. And so she may have been in persistent AF for a long time now. And if she felt better after her cardioversion, and it did recur, then that would be more compelling need to trying to achieve a durable maintenance of sinus rhythm. So this would involve discussion between moving toward repeating a cardioversion with a drug or ablation or some combination of both. So I think that most patients prefer to try medications before elective procedures. That can confer a small but non-trivial amount of risk, and without a 100% success rate for AFib ablation as well in the first time. I always emphasize that there's no cure for AF. And again, I would readdress modify the risk factors. But for her, I think that it may be reasonable just to sort of see how she feels when we get her back in sinus rhythm, at least at this juncture.
Is the fact that this patient's AFib was diagnosed recently rather than years ago, does that impact your calculus?
It definitely does. I think it's much easier to treat paroxysmal AFib, which is a recent diagnosis within a week, versus persistent or long-standing persistent, which is at least a year or more. It's always hard to know when they actually went into it, though. So if you can be confident that this is recently diagnosed, that's great. Oftentimes patients know like a light switch goes on and off when they developed it. But oftentimes I always ask the question of whether it's actually present for longer, because she's asymptomatic. She doesn't necessarily notice it, at least at this time. So I think that's much better to sort of get into rhythm control strategies when you actually have a recent diagnosis. It's harder the bigger the left atrium gets, and the longer you have AFib, the longer you have AFib.
Because it was more recent and her left atrium is not severely dilated, she has probably a better chance than someone who had very long-standing AFib or a severely dilated atrium of sustaining sinus rhythm if you pursued a rhythm control strategy. Thank you for that clarification. Okay, another question for you, Dr. Goldberger. I practice at the Boise VA. At the current time, we have one cardiologist who I'm always wary of overburdening. Do you think generalists are capable of leading rhythm versus rate control strategies? Or do you really think in most cases, folks should see a cardiologist for that expertise in guiding that conversation and knowledge of the antiarrhythmics and procedures?
I think it all depends. I think that many centers don't have immediate access to cardiology, let alone EP. So with telemedicine and e-consults, access is a little easier. And I think that cardiologists and EP should enjoy to offer advice and recommendations. For antiarrhythmic drugs, I would recommend additional expertise. There's a lot of nuance and there's a lot of follow-up with these medications. For instance, flecainide and propafenone bear a normal echo and stress evaluations with follow-up ECGs, lots of drug-drug interaction considerations. Class 3 medicines such as dofetilide merit careful selection, ECG scrutiny, inpatient hospitalizations, and so oftentimes requires that as well. Amio is very easy to give. It's very familiar, easy to initiate, but it has innumerable non-cardiac considerations. So monitoring these drugs is key, and it's time-consuming. But I find that a lot of general internists are actually very comfortable with these medications. They respect the potential for proarrhythmia, and they know when to refer. So I think it all depends on where you are. But I think that, at least at first, it's always nice to involve cardiology, just because a lot of things are a little bit nuanced.
Fair enough. I love it. So if I heard you right, or at least paraphrasing for myself, a cardiologist may be a little bit better suited to deliver these conversations, especially with including their familiarity with some of these lesser used medications, antiarrhythmic therapies. But, depending on your circumstances, generalists can often lead pretty good rate or rhythm control strategy conversations with our patients. One more question for you, Doctor. Actually, I got two more questions for you, Dr. Goldberger. First one is, a lot of my patients loathe being on blood thinners. Back when it was warfarin, they would complain about the rat poison and the monitoring. And even now that it's the DOACs, they just really don't like it. They complain about if they get a paper cut, they complain about bruising. They will take any reason to get off of these and run with it. Is the desire to get off of blood thinners a good reason to shift from a rate to a rhythm control strategy?
Yeah, this is always a tough one. I think that it's important to recognize the risk of developing atrial flutter after an AFib ablation can be upwards of about 20%. It's always hard to assess AF recurrence or development if it's asymptomatic. So I usually use the CHA2DS2-VASc score to guide this decision making. So wearables can also be of some benefit if the patient has one. Holters months after ablation are common practice, but it's not perfect, especially if paroxysm is developed. Bleeding risk is also a concern too. So if there's not a high bleeding risk, I usually continue blood thinners if the CHA2DS2-VASc score is at least 2 or more men and 3 or more in women for at least 1 year, then readdress it. And we're assessing stroke risk more fluidly now. And with these intermediate CHA2DS2-VASc scores, without other risk enhancers, may merit a discussion of coming off of it, but it's very challenging. And a lot of patients actually say, you know what, cost isn't an issue, I'm not bleeding a lot. The risk of developing this again is just not acceptable. There's a stroke risk, I'll stay on it. But a lot of patients actually really do want to come off of it. It's just a risk-benefit discussion, but I usually wait at least a year before deciding. And again, in the midst of all of this, it's all about modifiable risk factors. The more you can modify the risk factors, the chances of recurrence are much, much less.
Excellent. And if you recall, this patient kind of was interested in ablation specifically because it sounds like a family member had an ablation. Is ablation ever pursued as the initial rhythm control intervention, or is it generally reserved for those who fail to achieve sinus rhythm after, like you mentioned earlier, cardioversion, antiarrhythmic medications, et cetera?
Yeah, so the guidelines basically give a class 1 recommendation for upfront ablation for select patients with or without a trial of antiarrhythmic drugs first. So if you're younger, like 65 or less, you had structurally normal heart without a severely dilated left atrium, if it was paroxysmal, you have very few comorbidities, I might think about going ahead with an ablation as opposed to a cardioversion drugs. Especially if they are generally asymptomatic, so I wouldn't have to burden them with a drug just to make them feel better in the interim before ablation. If you have typical atrial flutter, which is a right-sided flutter, that's almost always addressed with a catheter ablation, given that ablation is very straightforward, high success rate, low complication, and it rarely, if ever, occurs. This is for flutter, that's right-sided. This is different than a pulmonary vein isolation, which is a strategy for atrial fibrillation, because that involves a transseptal puncture. You don't always get all of it initially. So unlike that pulmonary vein isolation, for flutter, we create what's called the bidirectional block on the right side. And that's considered curative. And the guidelines also will award a class 1 recommendation for AFib ablation over drugs. So it all depends on who you see. I think, again, finding someone who's young, this is a new onset, the echo looks pretty good, they're not very sick, I'm going to go ahead and say, you know what, let's just ablate this and see how we can do. Older patients, a lot sicker, long-standing, then I'm usually thinking about drugs.
What about heart failure with reduced ejection fraction? Is that a reason to push for ablation earlier, or do you still go through the usual order of events?
Right, so if you have heart failure, your options for drugs are very limited. Basically, all you can give is amiodarone, some cases dofetilide. And we learned from the Castle AF trial that patients with heart failure with reduced ejection fraction actually tend to do better when you restore sinus rhythm. That should make sense, I think, only because you're basically going to get a little more atrial kick, your ejection fraction could come up, and symptoms are better. So patients with heart failure tend not to tolerate AFib, especially rapid. So if that's the situation, I think that generally it's better to go ahead and try to get an ablation on board, unless there's a reason not to. So yeah, for heart failure patients, I generally am thinking more about catheter ablation as a long-term strategy.
Yeah, so it sounds like, not only do heart patients with systolic heart failure have trouble tolerating the medications that would be used for rhythm control. They also might get additional benefit from the atrial kick. So often those patients will go to ablation earlier. Makes sense. Okay, well, thank you so much for that. Let's shift gears and talk about stages of atrial fibrillation. Dr. Goldberger, you've done a great job of emphasizing the role of addressing the associated comorbidities. But at least to my knowledge, this is the first time these guidelines from the ACC/AHA have introduced the concept of the stages of atrial fibrillation. Do you mind walking us through the stages?
Sure. This is actually, like you said, a new part of our guidelines. So I think it's actually one of the most transformational and impactful parts. It's right in the beginning. It's not the sexiest part of it, but it's extremely important. So basically what we decided to do is modeled somewhat after the heart failure guidelines that addressed this years ago. So stage 1 focuses on many of the modifiable risk factors that we sort of alluded to. So those include obesity, lack of fitness, hypertension, sleep apnea, alcohol, diabetes, and tobacco. It's important to take inventory of these every time you meet a patient. So caffeine is also felt to be a trigger for AFib. And that's oftentimes patients will say, hey, doc, I stopped drinking coffee. I'm still getting these episodes. There's actually no benefit for stopping coffee. So your patients will be very disheartened to learn that they're going to be having to exercise more, stop smoking, take meds for hypertension. But they're actually going to get really excited about you when you say you're giving back their coffee. And that's actually one of the things to sort of keep in mind. Unless, however, you find that coffee is a trigger, in which case you have to sort of avoid it. So I think the most important things to sort of address right away are those things I just mentioned. Weight loss is really recommended. I think 10% of your body weight is what we recommend. We actually know that every 5 kilogram increase in weight is associated with a 30% risk of AFib. And oftentimes bring some of these data to the clinic to show the patients these graphs. If you ever read the Legacy trial, which is what Prosh Sanders did in Adelaide, Australia, he showed that half of the patients he looked at 1,500, with a BMI of at least 27 or more. If you had a weight management program that led to at least a 10% or more weight reduction in AFib, that actually led to a significant improvement in AFib without drugs or ablation even. And that was actually sustained over 5 years. And any weight fluctuation mitigated the benefit of weight loss. So that's actually really powerful information to sort of talk about. And you can talk about how weight loss may be achieved, and I think the GLP agonists are really changed the landscape going on. A sub-study of that Legacy trial called CardioFit, published just a short while afterwards, looked at exercise. And while you find that weight loss more than 10% is great, if you actually increase your activity by 2 METs, it actually conferred the best freedom out of all of it. And even again at 2 METs without weight loss, reduced the AFib burden somewhat. So even if patients come back to you and say, you know what, I've lost weight with exercising, but I just can't lose anymore. Maybe I should stop exercising. Definitely say no. The exercise is definitely going to help reduce the recurrences. These stage 1 patients oftentimes don't undergo echo or monitoring electrically. That's how sometimes I don't see them. Oftentimes internists see them or anyone else. But, they don't undergo these imaging studies, with the express intention of assessing a patient's risk of progressing to AF. But that oftentimes does happen. That's when stage 2 comes in, where you actually have what's called pre-AF, where imaging happens, Holter monitors happen. You actually see manifest atrial arrhythmias like PACs, atrial tachycardia, or atrial flutter. And then you discover that there's been structural changes, like a dilated LA, where you find valvular heart disease, or you find a hypertrophic cardiomyopathy, heart failure with both reduced ejection fractions and preserved ejection fractions, and coronary disease. So that's a little bit more. Now you actually have these things that actually are going to sort of be a prelude to AFib. And that's usually when we get involved. Stage 3 is akin to the heart failure stage C, where you actually have manifest AFib. Then stage 3 is further divided into 4 subtypes. Stage 3A, which is paroxysmal. Stage 3B is persistent. Stage C is long-standing persistent. And D is actually had what's called a successful ablation, how you define successful. And permanent AFib is stage 4. And there's a lot of mobility between stage 3A and 3D, because you could have an ablation, then go back to being paroxysmal again. And whether you can actually leave a stage is not well defined as it is for heart failure. In heart failure, once you're in stage C, you stay in stage C. In my mind, if you have a successful ablation and it hasn't recurred, you're still back to having risk for it recurring. So that kind of gets you into the sort of stage, stage 1 or stage 2. So again, this is new terminology. It's always hard to know how to use it for now. But the point here is this, is that the stages of AFib introduced a novel framework for what's called defining AF. It moves beyond duration. Now it focuses on a continuum of disease, which is very much like what the heart failure guidelines did years ago.
So I wasn't way off when I likened these stages to the heart failure stages, but you did point out some important differences. You stay in stage C when you're in heart failure, while as in AFib, you can move around between the stages. Interesting. So I'm looking at the guidelines right now, Dr. Goldberger. So you emphasize obesity, lack of fitness as modifiable risk factors for developing AFib. The guidelines also mention hypertension, sleep apnea, alcohol, and diabetes. I'm guessing you agree with those also?
Absolutely.
Yeah. Okay. So you talked about stage 1 being at risk, and we want to, as generalists, internal medicine or family medicine docs, we want to stop our patients from getting to meet you, Dr. Goldberger, by addressing these. Once you've already progressed to clinical AFib, to stage 3 AFib, so to speak now, does improving these risk factors still help, or is it just once the cat's out of the bag, you're stuck? Should we still be emphasizing these once you have AFib?
Absolutely. So the key is that we need to be attuned to modifiables at all stages. As a cardiologist and as an EP, we don't see patients in the early stages and usually get to patients in stage 3, like you said. That does not mean we should stop recommending lifestyle modifications, especially weight loss, exercise, alcohol, and so forth, when we see them in follow-up. If there's a recurrence of AFib after ablation or with a drug, it doesn't mean that we missed a spot ablating or the drug's not at a high enough dose. What it usually means is that we missed an opportunity to iteratively reassess the things that actually make the recurrences less. So lifestyle modifications being those things, especially hypertension, exercising, weight loss. They should be actively and iteratively emphasized throughout all stages. We have to recognize that it's important to know that around 60% of all incident AF can be attributed to a modifiable risk factor, hypertension being the most common. So if you actually address these things, you can significantly impact the outcome of your AFib, being symptoms, burden, recurrence, regardless of drugs or ablation. So definitely address these things every time you see a patient.
I can tell your passion for this topic, is really coming through in this STEM. We got to prevent AFib by addressing these. And then once patients have AFib, we can't lose sight of that. And like you mentioned, 60% of AFib is associated with at least one modifiable risk factor. That's a big number. And I feel excited by that as a generalist, as someone who can make an impact and help my patients. Okay, well, thank you. And I also think these stages are going to help me not only emphasize modifiable risk factors, but also make friends with my billing and coding department, who I'm sure are going to be pestering me soon to stage AFib as we've staged heart failure. Perfect. Let's close out episode 1 by summarizing key take-home points. Number 1, there are multiple modifiable risk factors that can lead to the development, persistence of atrial fibrillation, including obesity, lack of fitness, hypertension, sleep apnea, alcohol, and diabetes. And in particular, Dr. Goldberger urges continued or initiation of exercising and losing weight, especially 10% of body weight, as that will really help. Caffeine, if it's a known trigger for the atrial fibrillation, potentially reducing or stopping would help. But in big populations, caffeine is not really a major driver in comorbidities for atrial fibrillation. Take-home point number 2, there are now stages of atrial fibrillation. Stage 1 is at risk. Stage 2 is pre-atrial fibrillation, where there's some structural abnormalities happening. Stage 3, is atrial fibrillation. 3A is paroxysmal. 3B is persistent. 3C is long-standing persistent. 3D is status post-ablation. And stage 4 is permanent. Key take-home point number 3. Ablation therapy is often used for atrial fibrillation, sometimes upfront and sometimes later on. But I want our audience to remember that for typical atrial flutter, those patients generally get cardioversion and then ultimately ablation. So it's a higher indication for that in typical atrial flutter. Take-home point number 4. Maybe every patient doesn't deserve a chance at rhythm control or sinus rhythm, but every patient certainly deserves a thoughtful risk-benefit discussion of rhythm versus rate control for atrial fibrillation, especially now that East AFnet has come out, showing that for some patients, they really might get a lot of benefit from it. Take-home point number 5, don't forget that heart failure with reduced ejection fraction sometimes leads to ablation earlier because of difficulty tolerating antiarrhythmics and because you may need that atrial kick a little bit more if you've got reduced ejection fraction.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs, including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CME Essentials in Internal and Family Medicine. To learn more, visit oakstone.com.